Not every irregular period is PCOS or PMOS. In medical terms, irregular periods come under abnormal uterine bleeding or AUB. AUB means abnormality in menstrual frequency, regularity, duration, or flow in a non-pregnant reproductive age woman. A normal adult cycle usually occurs every 21 to 35 days, with bleeding lasting up to 7 days. Periods need evaluation if they are repeatedly too early, too delayed, very heavy, prolonged, occur between cycles, or stop for 3 months. The key physiology behind many irregular cycles is ovulation. The menstrual cycle is controlled by the hypothalamic pituitary ovarian axis. Pulsatile GnRH stimulates FSH and LH release. FSH supports follicular growth and the LH surge triggers ovulation. Estrogen builds the endometrium. After ovulation, the corpus luteum produces progesterone, which stabilizes the lining. If ovulation does not occur, progesterone is inadequate. The endometrium remains under unopposed estrogen, becomes unstable, and sheds irregularly. This is called anovulatory bleeding or ovulatory dysfunction. But AUB is not one diagnosis. The standard classification is the FIGO PALM-COEIN system. PALM includes structural causes. P is polyp, such as endometrial or cervical polyps. A is adenomyosis, where endometrial tissue is present within the myometrium, often causing heavy painful periods. L is leiomyoma or fibroids, especially submucosal fibroids that distort the uterine cavity. M is malignancy and hyperplasia, including endometrial hyperplasia, endometrial cancer, and cervical malignancy. COEIN includes non-structural causes. C is coagulopathy such as von Willebrand disease or platelet function disorders. O is ovulatory dysfunction seen in PCOS or PMOS, thyroid disease, high prolactin, perimenopause, stress, weight extremes, and hypothalamic dysfunction. E is endometrial causes, where local endometrial repair or hemostasis is abnormal. I is iatrogenic causes such as hormonal contraception, anticoagulants, tamoxifen, antipsychotics, or intrauterine devices. N is not yet classified, meaning rare causes that do not fit elsewhere. Evaluation depends on age and symptoms. In adolescence, an immature HPO axis is common, but heavy bleeding from menarche may suggest a bleeding disorder. In reproductive age women, pregnancy must be ruled out first because miscarriage or ectopic pregnancy can mimic irregular bleeding. After 40, perimenopause is common, but endometrial hyperplasia and malignancy must be considered. Basic evaluation includes history, beta-HCG, complete blood count, ferritin, TSH, and prolactin. If hyperandrogenism is present, doctors may check testosterone, DHEAS, and sometimes 17-hydroxyprogesterone. In PCOS or PMOS, metabolic tests like HbA1c, lipid profile, fasting glucose, or OGTT may be needed. Pelvic ultrasound is first-line imaging. Hysteroscopy or saline sonography helps if a cavity lesion is suspected. Endometrial biopsy is considered after 45 or earlier with obesity, chronic anovulation, PCOS or PMOS, persistent intermenstrual bleeding, tamoxifen use, or failed treatment. Management is individualized according to the underlying cause, severity of bleeding, degree of anemia, age, and fertility goals. In anovulatory AUB, treatment focuses on regulating bleeding and protecting the endometrium with combined pills, cyclic progesterone, continuous progestins, or a levonorgestrel intrauterine system. For heavy menstrual bleeding, tranexamic acid or NSAIDs may be used in selected patients. Structural causes need targeted treatment. Polyps may need hysteroscopic polypectomy, submucosal fibroids may need myomectomy, and hyperplasia needs histology-based management. In severe, recurrent, or treatment-resistant cases, especially when fertility is complete, hysterectomy may be considered as definitive management. So the aim is not just to make the period regular, it is to prevent anemia, protect the uterine lining, preserve fertility where needed, and not miss pre-malignant or malignant disease.